All right, let's talk about a trial you absolutely have to know for your exams. The ATTRACT trial. We're going to break it down so you can nail it. Not just what it found, but how to really think critically about it. Let's get into it.
So you get asked, how do we treat a big DVT? The textbook answer, right, is anticoagulation, blood thinners. And that's great for stopping a PE. But what about the leg itself? That's where the story really begins.
Exactly. What about the long-term damage? The leg can be left in a terrible state. And that's the whole reason the ATTRACT trial even exists. It asked a really simple but profound question. Can we do more than just stop the clot from traveling? Can we actually prevent the leg from being permanently damaged?
Okay, here's how we'll tackle this, just like you would in a VIBA. First, we'll set the scene, the problem. Then we'll get into the nitty-gritty of the trial design. We'll look at the treatments they compared, the shocking main result, and then dig a little deeper into the risks and rewards. And finally, the big takeaway, the final verdict.
Right. So if an examiner throws this at you, your starting point is not just DVT. You have to immediately frame the problem. The whole point of ATT wasn't about saving lives from P in the short term. It was about saving limbs from a lifetime of misery.
And that misery has a name. Post-thrombotic syndrome, or PTS. See, even when the blood thinners work, that big clot can sit there and just wreck the inside of the vein. It causes this inflammatory storm that damages the vein walls, totally trashing the delicate valves. What you're left with is a leg that's chronically swollen, painful. It can be absolutely disabling.
And here's the number you have to remember. This is huge. About half, 50%, of patients with a big proximal DVT will develop PTS within just 2 years. Think about that. That's a coin flip. It tells you that our standard treatment, while good for one thing, was failing miserably at another.
So this failure led to a really logical, almost common sense idea. They called it the open vein hypothesis. The thinking was, well, what if we don't just stop the clot from getting bigger? What if we actually go in there and physically suck it out? Clean the pipe out. The hope was that by getting rid of the clot itself, we'd stop the damage and save the vein. It makes perfect sense, right? But the big question was, does it actually work in practice?
And that's where the ATTRACT trial comes in. It was designed to answer that exact question. So let's look at how they set up this crucial experiment.
Okay, for your exam answer, you need to know the vitals of this trial. It was a big deal, a proper, multicentre, randomised controlled trial, the gold standard. Published in the New England Journal of Medicine in 2017, which tells you it's important. And they had a big sample size, almost 700 patients across dozens of hospitals. That means the results are pretty reliable and not just a fluke from one center.
So, how did they test it? Well, they set up a classic head-to-head fight. In one corner, you have the old champion, standard treatment. And in the other corner, the challenger, a new, aggressive, high-tech procedure.
It was pretty straightforward. They took all these patients and randomly split them into 2 groups. Group 1, the control group, got what everyone was already getting, blood thinners and compression stockings. The second group, the intervention group, got all of that, plus this new procedure called pharmacomechanical catheter-directed thrombolysis. Yeah, it's a mouthful, so we just call it PCDT.
So what is PCDT? Imagine sending a tiny little plumbing snake into the vein. First, it squirts a bit of powerful clot-busting drug, RTPA, right into the middle of the blockage. Then it physically chews up the clot and sucks out the pieces. It's basically a roto-rooter for your veins. The goal was simple: get that clot out and get it out fast.
All right, so this brings us to the main event, the million-dollar question. After all this fancy, high-tech intervention, did it actually work? Did it stop people from getting post-thrombotic syndrome?
The number one thing the researchers were looking for, what we call the primary outcome, was simple. Did the PCDT group have less PTS than the standard therapy group after 2 years? And to keep things objective, they measured this using a specific tool called the Vijalta score. It's just a standardized way to grade how bad someone's PTS is. And the result? It was a total shock. In the fancy procedure group, 47% of patients got PTS, and in the standard do-nothing extra group, 48%. Let that sink in.
Basically no difference at all.
Statistically, it was a complete wash. The p-value was 0.56, which means the result was totally random. So this expensive, invasive procedure made absolutely no difference in preventing the main thing it was designed to prevent. That beautiful, simple, open vein hypothesis, it pretty much went out the window. But hold on. A good consultant-level answer doesn't stop there. Because while the trial failed on its main goal, the story gets a bit more complicated when you look at the other things they measured, the secondary outcomes. This is where you can really shine in an exam, by talking about the nuance, the whole risk versus reward picture.
So, what did they find? Well, on the plus side, there was a small glimmer of hope. For the people who did get PTS, those in the procedure group tended to have a milder version. The rate of moderate to severe PTS was a bit lower, 18% compared to 24%. So, less bad, but not gone. But, and this is a huge but, it came at a price. The risk of major bleeding was way higher in the PCDT group. We're talking 1.7% versus almost 0.3% in the control group. That's a significant risk.
Okay, so let's put it all together. What's the final verdict? What do we actually do with this information? In an exam, this is the part where you have to deliver the knockout punch, the clinical bottom line. The ATTRACT trial was a game changer. It basically told us, stop, do not routinely use this aggressive procedure for every patient with a proximal DVT. Why? Because for the average patient, that significant risk of a major bleed just isn't worth the small chance of having slightly less severe symptoms down the line. It really poured cold water on the open vein hypothesis. Now, to be fair, you should also mention the criticisms. Some people argue the 2-year follow-up was too short, and maybe, just maybe, lumping all proximal DVTs together hit a benefit for the absolute worst of the worst cases, like a massive clot going all the way up into the abdomen.
Okay, let's wrap this up. If the examiner looks you in the eye and asks you to summarize the ATTRACT trial and its impact, here is your polished, safe, consultant-level answer.
Okay, let's break down why this is a killer answer. First, you state the main finding, clear as day. It did not reduce the incidence of PTS. Second, you show nuance. You mention the small benefit in severity, but immediately weigh it against the increased bleeding risk. That's critical. Finally, you give the definitive conclusion for routine practice, but you cleverly leave the door open for those rare, highly selected cases, like someone with a limb-threatening clot. That shows you're not just reciting facts, you're thinking like a consultant. And that, right there, is the legacy of the ATTRACT trial.